I'll call upon Dr. Rohit SAXENA, sir, President DOS, for his next talk on managing raised intraocular pressures.
Cranial.
Cranial pressure, sorry.
We just had a talk on intraocular pressure.
Sorry,
I think we are
I'm not
overwhelmed
impressed
by
by
the
your
glaucoma
questions.
that Dr. Kirti just presented, and thank you, of course. So while my slides get on, thank you everybody for coming for this DOS session. We as the host welcome everybody to Delhi for the APAO, and of course thank you very much for coming for this session that we are having today. It was a mixture of everything. We wanted to showcase some of the different surgeries and the different procedures that we do, and I'm proud to say that our surgeons are among the best in the world, what to say of India. So I'm glad we got the opportunity to showcase the work that our leading Delhi ophthalmologists do. So I'll just be presenting a little different topic, which many of you do not get a chance to see or talk about. So this is about raised intracranial pressure and how we can manage that, and I do not have any financial interests. So I'll just talk about this case, and this entire discussion will be based on this case. This was a 30-year-old female who came to us with progressive loss of vision, both eyes, simultaneous. She had prior history of transient obscurations of vision associated with headache. The history she gave us was that her vision had improved intermittently every time she had a lumbar puncture done or a CSF tap was done, and which had demonstrated high pressures, but transiently she would get a little better. But she, while being on on full acetazolamide, she could tolerate. Her vision continued to be very poor. So she was hand movements, both eyes. Motility was normal. We do see sometimes some abduction deficits. She was definitely heavily overweight with a BMI of 40. And other than this, there was no other neurological problem. So this was her fundus. You can see virtually atrophic discs. You can see a small splinter hemorrhage, sign of some amount of edema. We did, it's normally not necessary to do a fluorescein angiography, but we just wanted to document a little bit of edema, if any, and whether any other intervention is going to actually help. So you can see a small leak that was there in the left eye. The right eye was absolutely atrophic. You couldn't see any leak of the disc also. You could see the VER flash pattern was not possible. The VER flash showed a small tendency of a waveform, which is what we use just to take a call. So the basic interest to work this patient up like this was to know whether any surgical intervention is going to impact her visual functions or not. And that was our key area. Of course, part of a routine workup for the diagnosis of IAH and MRI was done, head and orbits, and you can see the thickened optic nerve sheath and that small atrophic optic nerves in the middle. So this is the donut sign, which you can see the thickened sheath with a lot of fluid. So we knew that there is a lot of edema fluid that is in the sheath around the optic nerves. And well, the thought was, let's give her a chance because she was not doing so well medically. So this is a procedure of showing you how an optic nerve sheath fenestration is done. The aim is to reduce the pressure around the optic nerve. The alternative to this is a shunt. We'll discuss that, but because the vision loss was the primary complaint and she was coming to us with severe visual loss, we thought that we'll give the optic nerve sheath fenestration, a less invasive and traumatic procedure compared to shunt surgery, a chance. So this is how we go ahead. This is conventionally just the way you do squint surgery. This is medial rectus was identified, isolated, sutures were passed, and the muscle was disinserted. So till now, this is the conventional surgical procedure you would do for, say, recession of any rectus muscle. So 6-ovicral suture, disinsert the muscle. This is the medial rectus, so you disinsert the muscle, and then our approach is to now abduct the eye. So these are traction sutures, ethibond or any suture you can use to create a traction and get the globe to be abducted so that you can approach the medial side of the eye. So these are traction sutures so that you can pull the eye away. The disinserted muscle is now posteriorly pushed. This is a malleable retractor for the orbital surgery. And after you retracted and separated the fat, you can see this is the optic nerve, and what we are separating or pushing away are the long posterior ciliary arteries and vessels. So that's what we are doing, and you can see the distended sheath, and we use a straightened keratome to make an opening, and you can see the fluid that has come out. So that's all the CSF fluid that has drained from the perioptic space. It's better to make a flap so that it remains permanent rather than just a split or an opening. So the flap is removed and a permanent window has been created, and subsequently you can just remove all these and resuture the muscle back and close the conjunctiva. So this is, the rest is just like any conventional, again, strabismus surgery where the muscle is now replaced to its original position. So this was just to describe you or show to you the optic nerve sheath fenestration procedure, and we'll show you how the results performed in this patient. So day 3, her vision improved from finger counting to 1/60. Day 21, by the 3rd week, she had improved to 6/18. She was on 2 tabs acetazolamide 4 times a day. For the initial 3 weeks, we generally tend to keep them off any acetazolamide because we would want to keep that opening there. The CSF will drain from that opening and prevent any fibrosis or any fat from obstructing the opening. If we start Diamox very early, then sometimes if the fluid is less, then you can have an obstruction or closure of that opening. So the aim was, so this vision significantly improved just on basis of the opening of one eye. So the other thing again that we realize, that you do not need to operate the other eye. You can just operate on one of the eyes, and the improvement is in both the eyes, and therefore actually we tend to operate the poorer or the worse prognosis eye so that we can get a benefit on both the eyes. You can see now we can have a certain central field that is recovered, and the patient is actually ambulatory. You can see the improvement in the waveforms of the visual evoked responses. So the management of raised intracranial pressure is to check the visual functions. Headache, prefer to refer them to the neurosurgeon for a shunt procedure. If the vision is the clearly more important function that is being affected, start with medical management, follow up the patient. If it worsens or if there is no significant improvement, think of a surgical intervention. And again, if the vision is the primary problem, think in terms of an optic nerve sheath fenestration. Of course, before you do anything like that, stop any drug, identify the cause. Sometimes, of course, weight is something that is very important. Control anemia, blood pressure, CPAP for obstructive airway disease. These are the medications that have been tried. Acetazolamide is the sheet anchor for therapy. Topiramate and diuretics have a very small incremental effect over acetazolamide, but anything helps sometimes in these. Many of us who've who've handled or managed to or attempted to battle the war on the bulge appreciate that how difficult it is to do weight reduction, and there is but adequate proof that weight reduction has a very significant effect on visual functions and management of IIH. So it's something that you must advise because it does make a major difference to not only spontaneously improving visual functions, but also having a long-term impact on outcomes. So these are the surgical options. We, of course, do optic nerve sheath fenestration. Neurosurgeons are referred to if there is severe headache or very, very high CSF pressure. So if it's a fulminant IAH, obviously a shunt would be better than just a small optic nerve sheath fenestration. So the aim is to reduce the pressures around the optic nerve, and of course, you would follow up with entire visual functions. There is a risk of early vision loss. You're operating right next to the optic nerve. So sometimes if the vision is good to start off with, you may have a risk of failure of the surgery or vision loss, but usually you tend to have less likely. So confirm IAH, make possible all medical interventions, and if required, do an optic nerve sheath fenestration. Thank you very much for the opportunity.
I think excellent presentation, sir. I've never seen an optic nerve head fenestration before. It was wonderful.
The most complicated surgery on an optic nerve. I think an eye surgeon would have never operated on an optic nerve as such, like this, on an optic nerve sheath.
So that is why I thought it would be prudent to show, surgeons the fact that